Welcome everyone. Julie Millard, I'm the president of our HIMSS Oregon chapter. Thank you for joining us today for our second virtual Lunch and Learn session for the Love of Facts Interoperability in Oregon. We have, let me get my, quite the session prepared for you today. But before we get started, just a couple announcements and encouragements from our HIMSS Oregon chapter. One is, please engage with us in the discussion today. One of the best ways to do that is going to be by using the chat feature. So if you can put your questions in the chat, then someone from our board will be able to turn around and share those with Laura Jantos, who is our moderator. And we can make sure then that your questions as we go through are able to be addressed by our panel. And please, if you have any feedback as well, so format of the session, content, what you'd like to see next, again, please use the chat feature to interact with us in that way. And then last, a shameless plug to say that if you enjoy the content in our programming, either today or have in the past, we ask that you please consider joining our programs committee. So as we come out of the pandemic, we're looking to do more and more with our Oregon HIMSS members. And one of the best ways for us to do that and make sure we're delivering content that resonates with you all is by having more of you participate in our programs committee to shape what that looks like. And then one of the best ways as well to stay informed on what's coming next is by following us on LinkedIn. So we have a new company page for the HIMSS Oregon chapter. We'll include a direct link in the chat so that you can follow us easily if you're not already. And we will be sunsetting 2 existing groups that exist that some of you may actually be members of. And so those will be sunset and everything is moving into our new HIMSS Oregon chapter company page. And I think actually I'm going to pause and just admit a couple more folks from the waiting room. Good timing. That gives you all a chance to see. Hopefully we do have our annual conference scheduled. You likely received a save the date announcement. We'll have more details on the programming and the actual agenda coming out shortly. So we're working to finalize speakers, topics, all of that fun stuff. But please encourage you to hold your calendars. June 2nd is the date for that annual conference. And we will be back at the DoubleTree Hotel in Portland. And of course, a special thank you to our sponsors. Without their support, we wouldn't be able to offer the programming that we do at the cost that we're able to put forth to you all. So please take a minute, recognize them, and yes, thank you. And lastly, now I will turn it over to Laura Jantos and the panel. She will be our moderator today. If you have questions, again, maybe since folks didn't hear the introduction, please take advantage of the chat. So any question that you put in the chat, we will be able to behind the scenes route to Laura so that you can help kind of shape the direction and the topics that our panel will be discussing in our For the Love of Facts Interoperability in Oregon session today. So with that, Laura, take it away.
Thanks, Julia. Hi, everybody. I'm Laura Jantos. I was a partner in a national consulting firm. I built their healthcare IT division. And 10 years ago, I had a traumatic brain injury. So I spent the last decade navigating the system that we all know so well and have worked in for so long and led my own recovery. I've gone back to consulting in the past year, and I'm really excited to be here moderating this session today and talking with all of you and understanding the current state of interoperability in Oregon as well as nationally. First, let's have the panelists introduce themselves. I'd like to start with Eric Maddox. Eric, why don't you tell us a little bit about yourself and your role at Reliance?
Sure. So Eric Maddox here. I'm the executive director for Reliance Health Collaborative. I've been here for about 5 years prior to coming to Reliance. I was the executive director and director of Health Information Exchange for the Nevada HIE, starting that up, and even before that, working in the Regional Extension Center work with the Office of the National Coordinator on EHR adoption, meaningful use. Don't hate me for those of you that had a painful experience with that. I promise it wasn't all my fault. And so I'm glad to be here today to talk about Reliance and our work with Health Information Exchange here in Oregon in the Northwest.
Thanks, Eric. Glad to have you here. Hey, Russ, you want to introduce yourself?
Yeah, my name is Russ Kite. I'm currently with Cambia Regents, and I've been with them for a little over 9 years, working for other Blues plans for about the last 15 or so, and all kind of in the quality space, lots of stuff to do with HIEs, stars, metrics. Currently, I work kind of in a space where I work with provider groups to help them connect to regents and send in data feeds. So I'm that pseudo kind of interoperability world, not quite there yet, but that's the space I operate in right now. And so all things that I can do to work with HIEs, provider groups, and payors, including a place like Pacific Source and other groups to work with the groups, the providers to get data moving back and forth is kind of what I do day in and day out.
Great, Russ. Thanks. We're looking forward to hearing more. Okay, Paul Matthews, good to see you. Why don't you introduce yourself?
You too, Laura. Hi, my name is Paul Matthews. I'm the Information Security Officer for OCHIN and the executive with oversight of interoperability for our collaborative. OCHIN runs EHR hosting services and data analysis services for about 21,000 providers across 45 states. And I've been involved heavily in Health Information Exchange since our first integration of an EHR into the Santa Cruz Regional HIE back in 2004, and I currently serve on a number of boards and committees, including the Sequoia Project, the eHealth Exchange Coordinating Committee, the Central Oregon HIE, and where I'm pleasure to have the pleasure of working with Eric frequently. And I've spent a lot of time doing interoperability to the point where it's more of the practical use of EHR interoperability. What is affecting the providers and what are they seeing in their use of those products? So thank you, Laura.
Okay, sounds great, Paul. So as I mentioned, I took a break off of consulting and being in healthcare IT to pilot my own recovery. During that, I did get, updates from HIMSS from time to time. And as far as I knew when I came back, everything's been solved. We have FHIR, we have APIs, we have all sorts of new regulations, like everything should be working perfectly. So why don't you all bring me up to speed on what really is the current state of interoperability in Oregon and nationally? And why don't we start with Eric?
Well, you're right. It's all solved with FHIR, right? Yeah, there are a lot of initiatives that are really driving interoperability, driving data exchange. From Reliance's perspective, as a community-based HIE serving the broad spectrum of the healthcare continuum here in Oregon, most recently, and that's maybe the last 18 months or so, what has really been driving interoperability, what has really been driving HIE adoption for us has been the increased, adoption of alternative payment models, risk-based contracts, the creation of clinically integrated networks amongst our larger health systems in the state. And that seems to be one of the overwhelming and greatest motivators for participation in health information exchanges like Reliance. And that's probably followed very, very closely for us by the passage and implementation of the Cures Act, and more recently the CARES Act, really close names there, but those have been really the drivers for us here in interoperability. The standards, the things like that, those are things that make it go forward. While we have FHIR and it's has potential to solve some issues, we have TEFCA that's coming down the line. We've had national exchange initiatives for years now. Some are picking up speed. It's really those more recent events that I think are driving interoperability and really motivating folks to get connected to health information exchange methodologies here in Oregon right now.
Sounds great. I know there was a question about clarifying FHIR, and someone put a link in the chat on that too. Paul, do you want to add anything on what's going on nationally and what you're seeing from these pressures? And then I'll have Russ kind of bring it into the value-based care model that Eric brought up as well.
Yeah, I think so. What I see driving this a lot is we have more and more patients being sort of transitory in their care, definitely an increase in the amount of patients in the referral processes as patients transition out to a specialist. And what we're seeing is the regulatory changes are helping drive standardization of data transfer. That has led to a massive increase in the movement of data, but especially a movement of data for patients to gain access to their information. And I think that that's a big change that is occurring. The curation and administration of data for patient level interaction is starting to push for HIE adoption in a much larger way. I would also say that along with Eric's comments, that the regulatory changes that have come out, the Cures Act, the CARES Act, those have pushed us towards more standardized, more uniform ways of exchanging information, and have pressed for the sharing of additional information by changes or a more aligned way of thinking about the requirements to share data externally and with a patient.
Thanks, Paul. So Russ, take us into value-based care and what's really pushing this from your perspective.
So from our perspective on the payer side, as value-based care has grown kind of exponentially over the last couple of years, just the number of lives that are in these contracts dictates a different way of moving information around and understanding how the population is actually, how healthy the population is, and if the contract minimums, the SLAs, or those agreements for managing those populations are being met. So things like blood pressures, A1Cs, kind of those normal quality metrics that we've been looking at for many years. Facilitating a way to move those rather than a physical chart has been kind of the impetus for us to really put a lot of effort and resources into working with the provider groups in figuring out the best way to move information on, instead of 500 people, 25,000 or 50,000 people. It's just the numbers become so large that the infrastructure that we used to, kind of get away with just won't work anymore. So we've been kind of slowly kind of prodding different ways with the different provider groups, the different EMR systems, HIEs, whatever's going to work best. And we found that there's lots of different ways to do it, but the end goal is still the same, and that's to be able to move almost population level data from the providers over to the payers, and then from us back over to them. So this kind of this bi-directional loop that we're trying to build out, so that we better understand these subpopulations that we're managing within the value-based contracts.
Thanks, Russ. That's really helpful. Can we get a little bit more technical here? I don't want to get super technical, but there are a lot of concepts here that I think we probably need to clarify for people. And I used to have friends that were in healthcare IT thinking like, this should be really easy. You just take this system and this system, you just kind of plug them together and everything should work. And clearly that's still not quite there. Coming from HL7 and then through various standards and now FHIR and APIs, I think we do need to kind of touch again on specifically what the process looks like for interoperability. There seem to be a lot of options out there. And are things getting easier, and what specifically is making things easier? Why don't we start with you, Russ? We'll go back to Paul and then Eric this time.
All right. From my perspective, I think there's a limitless amount of options out there, and that's both good and bad. And I think that's kind of predicated upon all the different EMR systems, how provider groups and payers use those. You've seen one instance of Epic, you've seen one instance of Epic. And that's great because the end user, the business, is using it the way that they like and that they need, that works for their model. But that doesn't necessarily mean that it's going to be an easy downstream thing to work with. So we're trying to navigate all that kind of custom work and one-off builds and coming up with a better way to do things. And I see all kinds of really neat work being done by Da Vinci and Argonauts with things like CDEX at Clinical Data Exchange, and they're doing some really neat work. We have a great team internally that does interoperability work, but it's complicated. The stuff doesn't happen overnight, and unfortunately it's expensive. It takes a lot of effort and resources. So it's not. I don't think it's working nearly as fast as everybody would really like. But like I said, I've seen some really fascinating ideas, different ways to solve the same problems. And I think at the end of the day, we'll see some of the fringe things kind of just kind of fall away, and we'll be left with a number of solutions, not one that wins, but 3 or 4, because there just will not be one solution that makes us all happy. So I think we need to be prepared to come up with 3 or 4 or 5 that we can support long term.
So Eric, how is Reliance working through this? How are you? It must be crazy to manage all these different standards and approaches and organizations. It's just, what does it look like for you, and where do you think it's going?
Like Russ said, we're working through it slowly. Like everyone else, we're working through it slowly because there are a ton of different ways, right? There are a ton of different options. For us, it's really about here are all the options, here are all the things you can do. It really is about identifying for us, what is it that a hospital, a health plan, a SNF, a doctor's office, a lab environment, whatever it is, what are you trying to accomplish by connecting? Is it meeting those regulatory requirements? Is it sending the CCD with the US CDI elements for the purposes of saying you're doing that to the feds? Is it getting your system's laboratory data out into the community and available for physicians at the point of care? There are lots of different uses. No, there's no one standard, there's no one mechanism to do that. That is the silver bullet. So for us, it's really about working in great detail through what is it you're trying to accomplish, and then finding the right mix of standards and transport methods to do that. When fire was starting to pick up steam, maybe 2 years ago, we used to get asked regularly, do you support fire? Yeah, absolutely. The HIE can support fire-based integration. What do you want to accomplish? Oh, we don't know. We just want to make sure you can do fire. Right? And so there's a lot of those types of questions. Can you do this standard? Can you do this? Well, until you understand what you want to do with that, until you understand what you want to accomplish, it's really difficult to find that particular mix. I think we're getting better as an industry, as a community. We're getting better at identifying those use cases and thinking in that manner. And so the next layer of that, and the next place where it becomes more complex, to Paul's point, becomes about the data quality. Do we have the content? Yes, you've built the fire integration, but does your workflow capture the content? And are you putting it where you're supposed to put it in your EHR or your claim system or whatever it is, so that that content, that payload, can be packaged up and sent via the standard and can deliver on that use case? That's where we see the next level of work from Reliance's perspective being, we're starting this year, but it will really pick up steam in the coming years, where we start paying attention to that data integrity, that data quality, because we'll solve the standards, we'll figure out how to define what we're going to do with all the standards and the methodologies. And now it'll become about the availability of the right data at the right time.
Thanks, that's really helpful. And people, please, add your questions into the chat, so it's not just me asking questions. But I think what I'm really curious about now is if you can give me some really specific use cases of things that you've accomplished or we're accomplishing in Oregon right now in terms of interoperability that we weren't able to do a couple of years ago. Anyone have any thoughts, any suggestions?
Well, I could probably, one of the big ones I would think is under the Cures Act, and also under the original Meaningful Use Act, was the implementation of FHIR to allow patients to access their clinical records. And that sort of led to the Apple Health applications, I want to say, I always forget the name of the other application from the Android side. I think it's Common Health. I will look that up really quickly for you. It is and I'm not seeing it there. I believe it's the Common Health application, which is the Android app. What that allows a patient to do is, on their mobile device, is program their device, point to an endpoint of a hospital or all of the caregivers that they have services at, and then bring that information back and combine it into an individual health record on their phone. They can then take that application data and they can feed that for integration into third-party apps. So they might have a medication list that they want to review that medication and actually see, what does that mean if I actually change this medication? Or a healthcare payer may turn around and go, I can look at the specific programs that I offer as a payer in my list of services and recommend, based on the actual health information within the medical record of that patient, actually recommend a specific coverage within their program that is available. And I basically tune this towards the patient's needs. The same with looking, if I'm a diabetic patient and I pull my information in, there may be information in there that a specific diabetic app might be able to give them a much more defined and usable view of their information that they may not be getting from directly in their conversation with their provider, right? They may not understand the information being shared, and the sort of crowdsourcing of information being shared back through these application providers may simplify it in a way that they actually are able to participate more in their own care. And I think that's a huge change from sort of the log into a web portal and look at the information yourself, but being able to actively integrate that information into these other third-party apps. Think of the Kayak for signing up for, for a vacation, a flight, a hotel, a rental car, and being able to do it through one place.
Thanks, Paul. Russ, do you have any insights?
Yeah, I've got I guess my examples are kind of these more in the background, and what we've been doing over the last 5 or 6 years, we've been kind of poking and prodding and trying these different things out, and almost like predecessors for what interoperability really should be. And what we've done is we've reduced the number of medical records that we're requesting from the provider groups. And it's not anything really fancy and something that is always published out there, but we request a crazy amount of medical records every year, hundreds of thousands, and being able to reduce that even by 10 or 15 or 20%, not only is it a cost savings, but it's just provider abrasion, it's security issues, it just rolls out to all these little kind of fingers. And any time that we can make progress, and we have made some significant progress in both reducing the amount of charts that we're requesting, as well as improving our quality metrics. So again, that's an efficiency standpoint. For me, I think it's just a sigh of relief that I can go to a provider group and say, hey, I only need 8 or 15 records instead of 100. That's, that becomes a very big deal, especially for the medium and small groups, because, for me, I'm not the only person asking for them. It's me and 10 other payors that are asking for these medical records at the same time. So that's kind of like, again, maybe an oddball example, but that's definitely something that we've been testing out for the last couple of years. And in seeing that success, it's like, okay, that's where we definitely want to keep building on this, because we know it works and that people are seeing good value out of it.
That's a great example. Actually, I'm going to turn it over to Eric and ask, when we talk about reducing provider burden, are you seeing things where Reliance is also helping to take some of the cost out of the equation? Well, yeah, I know I've got a great question in the chat that I want to pick up next.
And I was going to build off of Russ just to say it's not an oddball example. I think don't underestimate the impact of that efficiency of some of those savings in process that we're seeing. I would echo what Russ said. We're seeing, what are we doing now? What can we do now because of interoperability? We couldn't do 2, 3, 4, 5 years ago. Let's not even talk about 10 years ago. But just a few years ago, we're now seeing the ability to be far more efficient or have impacts on efficiency and effectiveness in a practice, because interoperability has become more functional. It's become more practical. It's become simpler to implement within an EHR. EHRs have finally caught up in their ability to populate a CCD correctly, in their ability to move data in a more robust way than they were even a few years ago. We're now able to see some of those efficiencies where we can say, if you have participated in this health information exchange, if you are doing these things with HIE, now you don't have Russ calling you asking for charts. Now you don't have 5 other Russes from 5 other health plans calling and asking for charts. And oh, by the way, you now don't have hospitals preparing for pre-op calling and asking for these things. You don't have, and it all rolls down. That also increases a practice's, in particular, a practice's capability to now participate in those alternative payment models. A lot of those risk-based contracts, the APMs, all of those things, they require data. They're driven by near real-time content. And if you don't have that capacity out of the gate, it really can hinder your ability to participate in that in a really successful way and see the financial benefits of participating in those models. And I think we're seeing that now because we do have broader participation with a broader data set. Folks are realizing those efficiencies.
Thanks, Eric. So let's talk a little bit about some of the vendor-vendor integration or interop models and how those relate to organizations that aren't on the same EHR platform. Paul, can you pick that up? But the specific question in the chat is, any insights for hospital systems using Epic, but clinics don't? How do we bridge that gap? I mean,
yeah,
I think my broader question, without being maybe too vendor specific, is understanding the benefits of what we're accomplishing in the state of Oregon when we're on the same product and making sure we're not leaving others behind.
Yeah, it's a great question there. So I'll sort of lay it out a little bit for the audience. So you have multiple vendor networks out there that provide EHR to EHR connectivity. So great examples would be iShare on the next-gen side. There's the Clinical Works Hub. There is the Commonwealth integrations that are used by groups like CPSI and others. And then there's the Epic Care Everywhere network, which is used heavily between Epic organizations. Each of those has some advantages to them in their speed to implement newer and broader technology to move data, because they control both ends of the communication. So while they'll use standards to move information, they are able to produce, standardize, and integrate the data within the EHR in a standardized way that allows it to be developed faster and delivered to them as a way to exchange data. Then you have the ways of exchanging between EHR and other platforms. So there's the ability to send a CDA document to the Regional Health Information Exchange that has access to that information in its clinical document repository. And it can be accessed by providers through a web portal or through query of that regional exchange through either direct integration or through other exchange networks and frameworks. You could also exchange data between EHR and other platforms using the eHealth Exchange, as an example, which is a national network, or the Care Quality Framework, which connects up. It's a framework of vendors, which includes groups like Epic organizations connect to it. A lot of health information exchanges. You have Commonwealth, which is a large group of vendors that produce their own network called the Commonwealth Network. They can all exchange data using the same CDA document methods to send clinical document summaries backwards and forwards. The gaps that exist in most areas that we see across the country, and I'm connected to about almost 25 regional health information exchanges right now, and each of the national networks, comes down to is they want to exchange with specialists, and the specialist may not be connected to any of those systems, or may only be connected to one of them. And it's not that they can't get to the data in the other system, they don't know who to query or what to query for in a provider office to get to it. I'll give you an example. A provider might be on an Epic platform and they want to exchange data with a group on CPSI. While the connection itself would be from an Epic system through Care Quality, Care Quality would connect them to Commonwealth, and Commonwealth would then connect them to the CPSI system. And so they would need to know how to get through that in a directory, and the directory is the important piece. How do I identify when I query this organization? How do I find them on the network? And how does it automate the response back to me? That's the missing gap. That's where everybody is struggling, identifying how to find the path to the information. Now, at a state level, I think Eric would probably be the better person to talk about that at the state level. I would say that connection to your vendor networks, Epic is 85% of healthcare EHR platforms within the state. However, it doesn't take care of a lot of the smaller practices across the state that might be, or smaller hospitals that might be using other products. And that's where your regional exchange is really tying in those gaps together. And I sort of pass it over to Eric to comment on that further.
Yeah, and that's, when we start talking about, Epic, we hear that commonly, regularly when we are in the community and we're talking to folks where there's an Epic presence in some fashions. Well, Epic's in the community, so do we really need to participate in health information exchange? And again, there's no silver bullet. Paul just went through all of the different exchange methodologies and networks on a national scale. No single one is going to deliver the full range of content that you may be looking for on a patient. And what we know here in Oregon within the Reliance network is that when we look at our patients inside the HIE, on average, those patients have records sourcing from 6 different electronic health records, Epic being just one of those.
Right.
And when we look at the patients that have data in Epic, the number actually goes up. If you have your data someplace in an Epic system, it goes up to about 7.5, right? Rounding numbers, but it goes up to about 7.5 EHR. So you're actually more likely to have your data in more EHRs than just Epic if you're seen in an Epic environment. And that is where we come in to break down some of those silos. Ideally, a regional health information exchange is connected to many of those, maybe not all, many of those national networks, to where it's go to the regional HIE and they'll use their own network plus reach out to those national networks to bring that data set in. As Paul mentioned, the key is knowing where the data are. And I think that's where the path we're starting down with TEFCA, the IDEA long-term, TEFCA acronym, Trusted Exchange Framework and Common Agreement. Yeah. The mouthful is TEFCA. And the idea there is, press the button once, have it query the entire country and bring you back the relevant data. The challenge there is knowing where the content is, knowing where the record locator service is what we typically call it. And I think that's where you will see local HIEs, regional HIEs like Reliance start to play a big part in TEFCA. We're typically going to know where things are on a local level and have some capacity to respond to that on a national level.
You're on mute, Laura.
Yeah.
Of course. Thanks, Eric. Russ, do you have any comments on this?
Probably personally, I like the HIEs being kind of in the middle, because they're kind of the agnostic solution. Is that you have the payers kind of on one side and the providers on the other. And while direct connections are something that we do, and that's basically what we have been doing for many years, it just doesn't make sense in the long term for exchanging information. Maybe it works really well for really big groups where we have really big contracts, but it just doesn't work well for everybody. And I'm one of, again, 8 or 9 payers, and maybe I have a bigger contract with specific groups within the state where a different payer has different contracts. So I might have a skewed perspective on what I think is more valuable. Maybe OHSU is more valuable to me in Oregon than Providence or something. I'm trying to put an example out there where we might do different work or put different resources into it. So I like the HIEs as being that middle ground because it allows everybody to go to one central hub, again, an agnostic kind of hub, to be able to exchange the information. And again, so that's kind of my perspective. Is it makes more sense to do it that way, and I kind of like it that way, but not that that's the only solution. It's just kind of one that I think is the most pragmatic way to look at it.
Okay. Thanks, Russ. So let's talk about medical consumerism a little bit. I mean, when I think about the effort going into either deploying a vendor solution out across a community, so there is some standardization and ability to do exchange, or connecting through an HIE, I'm wondering, is there anything going on from a medical consumerism perspective or from a disruptive perspective that's going to make this faster or cheaper for people to get their own data in the future?
So we keep coming back to FHIR a lot. But FHIR is really the mechanism that enables an individual to gain access to their clinical data from the healthcare environment. And that includes anybody that falls under the Cures Act, under the 21st Century Cures Act. It required all actors within inside of the healthcare system to enable FHIR to grant access to the clinical and financial information of the patient to the patient in real time. The question comes up to is, are the applications there, and has everybody implemented those requirements in compliance with the regulatory language? And those are big gaps. The other one is thinking about how am I going to get the information en masse to an individual rather than integrating directly to each one of their care locations? Can I do that through a central solution? The TEF, the Trusted Exchange Framework, the common agreement that Eric alluded to earlier, has a requirement in there that people look at the implementation as a qualified information network to share what they call IIS, individual access services. So centralizing the ability for a consumer to gain access to their data. That brings with it some very technical requirements. How do I know the patient that's asking for the record is the patient that is authorized to see the record? And how do I uniquely identify that patient and then give them permission to their records across the Trusted Exchange Framework? So similar to how do I make certain the person accessing the portal to talk to their provider on the EHR is the person they say they are. And so that's a big change that's going to come with the consumerization of product.
So I've known you a long time, and I can clearly tell you when I'm confused. And I'm confused, you know, and I hear a lot about unblocking, right? And I hear about people being able to access their information. But on the other side, I know organizations have spent an awful lot of time and an awful lot of effort and an awful lot of money to have these big stores of data that they're using for competitive advantage.
Mm-hmm.
And part of me wonders, is this really real? I mean, are people really going to have access to their own information? Is unblocking really going to happen? Eric, you're kind of nodding. What do you think?
No, that's really common. When we'll go back 12 years ago or so, when meaningful use was rolling out, there was funding to start health information exchanges. We used to hear regularly as HIEs the comment from entities, incorrect comment, but their approach at the time was, look, we can't share this with you because it removes our competitive advantage. Your healthcare information is not a competitive advantage tool to be leveraged, period. And I think we are finally at the cusp of, with standards, with interoperability, with regulations, the cusp of actually freeing that content for the consumer. Even in places, like for us, if you came and said, hey, do you have direct consumer facing applications or functionality within Reliance? No, we don't. We won't. To Paul's point earlier, it's about deploying the right series of applications in the right way to meet the regulatory compliance requirements. We will act on the back end with folks that do meet those regulatory requirements, that do have some of those applications provided. So example, we have a health plan we're engaged with right now who is working to expose that data, is working to make sure that the patients, their members, have the access to their clinical data, not just the clinical data the health plan holds, but rather the clinical data that the HIE holds. The health plan will do the ID proofing. They'll meet some of those regulatory requirements, but they'll draw the content from the health information exchange to help push that out into whatever that happens to be, whether that's Apple Health, Google Health, whatever the application is that they happen to be using. And so you are on the verge of that, and it's all driven by interoperability. It's all driven by regulations, and folks that are finally starting to take those efforts. I think that's, to put in a plug for HIEs, community-based HIEs in particular, like Reliance. That's also the place where we play a really good role, where once the content is there, it's no longer subject to somebody using it for competitive leverage. It's now there for the patient to say, this is the way I want to bring my data out, or this is the way I want my data shared. It's no longer a doctor office being able to say, I'm not sharing this because if I do, it'll be used against me, or if I do, it'll be used in this way, and I don't want to allow that.
Laura, I'd like to expand a little bit on that one, which was the 21st Century Cures Act requires, and it's law, that you are sharing that information with a patient, and that only a provider in a conversation with that patient can make an exception that says, I'm not going to share that information with you. And so when we think about patient data exchange, today, if a patient was to reach out, contact their provider and say, I want access to my clinical record via FHIR, the provider organization is required under law to deliver that record back to that patient and to provide them access. There's no way around it. The real question comes up to then is, well, what about the tools for that? Again, the patient can choose any application of their choice, be it a commercial application or one developed in a basement, and it can be used to reach out to that provider record and that payer record and to the other locations of service and pull that data back into their own system. So they have full access, and there's no denying it anymore. The Cures Act opened up the exchange and very clearly articulated what the requirements are for providers for the release of that data. You're on mute again.
Russ, do you have anything to add?
I'd probably say kind of dovetail on what Paul was talking about with like we call it member matching, but making sure that we're providing the right information. I can't count the number of meetings that I've been in with just brilliant people on our side talking about making sure that works. Never once have I been in a discussion where anybody said this is going to take away our competitive advantage. It's a very benevolent kind of perspective, which is really cool because that does creep in when you start talking about business and money. And so I've heard all of these people going, we want to make sure that we're exposing the right data. And so we have our privacy folks and all of our folks that do nothing but just think about how to do this right. Have conversations about making sure that PHI is being exposed to the right individual versus any kind of discussion around competitive advantage. So that the last 2 years, that's been a really neat kind of shift in seeing that push towards making sure that we can do this right, because we look at that empowerment as a very powerful thing for our member base. And so we're pushing directly towards that and just making sure that we do it right. I think that's, again, going back to that, we'd like it to go much faster, but in these type of cases, rushing when you're talking about something this complicated and this important is again, that's probably not a good idea. Let's take it nice and slow and make sure we do it right. But it's a very big push on our side to make sure that we get that stuff done correctly and that we do it as quickly as possible.
Thanks, Russ. There are a couple of good questions in the chat. The first is kind of questioning the meaningfulness of the actual information that's in the EHR, and I'm going to flip it a little bit. You know, when I've been navigating my own issues, I've found that the information that I'm being given by providers is information they want me to have to serve some of their own purposes, providers and payers, frankly. Pay my bill, how was my bill paid, show up to my appointment. But I'm not seeing things that incorporate my feedback, my information, my value, you know, my experience. And I'm wondering if there is any venue to really incorporate information from patients that's being pursued. Now, I'm on an NQF technical expert panel around patient-reported outcomes to patient-reported outcome performance measures. And I know we're working on it there, but I feel like we're missing a huge piece of the puzzle in making information really meaningful to people and engaging in their own care. And it's more of a bi-directional type of thing. Is anyone looking at capturing information directly from people? And especially with the explosion around remote patient monitoring and other devices, how is that coming into play? Russ, why don't we start with you?
Yeah, so it lands in two buckets in my world. On the quality side, we work with NCQA rules, National Committee for Quality Assurance, and so what we call member reported is kind of it's a gray area. We're not allowed to use a lot of that data. But that doesn't mean that we haven't spun up really cool programs with heart rate monitors that we've been supporting the last couple of years in different communities. We've been kind of pushing that envelope to see what we can do, and working with NCQA and other organizations to try to integrate more of that. And social determinants is another really good example of that, is just race and ethnicity. We don't collect that data. We never have. It's just kind of been one of those things that we just stayed away from, and now it's centralized to so many things. And so the best source of data is from the person. Reach out and talk to somebody and actually get it from them. And so we've been, again, being very, very cautious in how we integrate that information and how we disseminate that within our programs to make sure that it is usable. But again, it's a huge kind of effort to look at that and go, where can we get this information, word of mouth, get it from the individual and integrate that into the medical record, into the medical claims, and have this nice, and I'll even say it, longitudinal medical record, that kind of golden goose that we've all been talking about for many years. But it's a really big deal. It just depends on which programs that we're looking at and how we're able to use that information.
Thanks, Russ. Eric, there's a question that came in. I think it's directed towards you. It's around secure messaging, referrals, and secure messaging between providers, and how that fits into the interoperability discussion, such as direct. Is the state still working towards connecting all providers to direct? Can you kind of explain what that is? Is that up your alley?
Yeah, Paul could probably do it as well. But direct secure messaging, it's the most basic way to describe it is secure email. Email that operates within its own closed network, so to speak. It's not like what we normally talk with on a daily basis in our jobs. Direct secure messaging, or short direct. I think direct is still a viable exchange option. It's used daily by providers all over the country, and including here in Oregon. Again, is it part of the equation? Is it part of the interoperability discussion? Absolutely, in so much as, does it address a use case? Does it accomplish something that you are trying to accomplish at the point of care or within your population health management, et cetera? The answer to that is yes, direct plays a part. I don't think, and Paul might know better, I don't think direct is really called on heavily in any of the recent regulations, any of the recent legislation that's passed that we've been talking about. It's acknowledged as being there, but it's not something that's being pushed in the same way that FHIR is being pushed, in the same way that some of the other standards are being pushed. I know here in Oregon, the state's initiative, I think it ended about 2 years ago, roughly. It ended about 2 years ago, and it was primarily a funding requirement. Even here within Reliance, we offer direct, we have direct capabilities. It's got very low adoption because it's now built in and native to electronic health records for the most part. And so it's just a function of the health records. I think what is missing in the equation that maybe the question was alluding to is the directory. How do you know somebody's email address? How do you know someone's direct secure messaging address so that we can move transition of care documents onto them, or we can remove a referral onto them? And that directory, I think, is still missing. We had here in Oregon a provider directory initiative. Again, funding requirements, I think, have brought that to a halt for the moment. Might pick back up in the future, who knows? On a national scale, you have vendors like SureScripts that do operate direct secure messaging networks, do provide directories on a national scale. So there are ways to start addressing those, but there are gaps in making direct successful. It really just depends on what you're trying to accomplish.
Yeah, Laura, I would say probably to bring it to a practical level, direct secure messaging is very useful in the transition of care, especially around referral. And it is the basis of two things. One, it's the basis of the referral mechanism used between Epic organizations and what they call the referral management module that allows bidirectional synchronization of referral data between the specialist and the clinician that referred them to synchronize the entire process and move the information needed when both accepting a referral and communicating back to the provider after the visit has occurred. There's also another process called 360X. It's a neutral project of the ONC that allows EHRs to talk to each other to basically allow for that referral process again to be synchronized between different systems. Eric talked about the directory of providers. Direct Trust is the one that really takes on the sort of curation of the provider list inside of that system that a lot of organizations feed to, like SureScripts and other direct messaging organizations called HISPs. They send their data into Direct Trust, and it creates a listing of about 400,000 providers nationally in a single directory that you can download and then import into your own infrastructure or use through your other vendor's web portal or integration. So Direct is extremely useful. We use it very heavily especially between providers coordinating care, especially around births, where a patient is going into the hospital and they're communicating to the provider between the hospital system for the birthing center and back to the primary care provider. The biggest issue is not necessarily does it work. The question is who am I sending the referral to? And the biggest issue about referral is you don't refer always to an individual, you refer to an organization. And a lot of places don't have organizational addresses set up. They have individual provider addresses set up. And so the workflow doesn't match that of the fax. So direct messaging is a huge portion of the axe the fax capability because it would turn around and allow that bidirectional exchange in a meaningful way for referral transition. And that's where the value is.
Thank you. Let's, we've got a couple minutes left, I think. There's a question about predictions for the future, specifically around cutover from care quality and Commonwealth to TEFCA, given the lack of incentives. Russ, you want to start us off? And
actually, I know that at a really high level, so I think probably much better at. I'm dangerous at best when it comes to getting into care quality and TEFCA. I know of dangerous.
Well, any other predictions? Any great predictions you want to share with us?
Yeah, what I see is it's probably going to be another couple of years of a lot of effort in doing some really cool stuff, building some neat things out, and seeing a good portion of those fail. And because that's just, that's how innovation is. You got to keep building. I think at the end of the day, we're going to be left with that realization that we do need more than one solution. FHIR's the new shiny thing right now, and I think it's super cool, but I know it won't solve all of our problems. And so we need to be ready and understanding that there's going to need to be a menu, a number of different ways to solve problems so that we can work with the non-epics of the world or find these band-aids if we need to so that we can get where we need to be. Just standing in one place and holding firm, I don't think is the right approach because we're going to leave people out. So that's me.
Thanks, Russ. Paul, any brief?
Yeah, very brief one. So I think that the path is going to need a 2-year plus sort of roadmap towards or runway to basically get to a point where the TEF is a usable network. Otherwise, it's just adding to the fragmentation of health information exchange. If it is successful, and only will it be successful if there becomes a mandatory requirement to utilize it because of the voluntary network, then I think you will find that it could end up superseding the care quality network as the mechanism for exchanging data at a sort of a national level. And so the writing is on the wall that either it's going to be wildly successful in a few years because somebody will mandate a requirement for connecting to federal agencies through there, or even mandated using it for reporting to public health. And if that occurs, then we will see a drop in a number of things. We might see a drop, we'll definitely see a drop probably in care quality. There's a big risk there. We may see a drop in the numbers of regional health information exchanges if it is successful, because the QHINs, the central communications vehicles, look and feel like regional exchanges within that mechanism. And it would definitely have a major effect on the long-term ability to exchange data across this nation, because it could, for a long period of time, actually delay or even disrupt information exchange if it is not implemented well and implemented quickly. So there's a lot of risks with TEF that are coming out of it, but with those risks become a lot of rewards if it is wildly successful, and that'll only come if it's mandated.
Thanks, Paul. Eric, what are your thoughts? What are your projections?
I'll agree with all of that. No, without it's a couple years out before we see anything, and without a mandate, it's even longer before it takes off. We did this with the National Exchange, right? With what is now eHealth Exchange. That's 10 years old or better. The INWIN, right? The National Health Information Exchange. It's only picked up speed in the last couple of years because it took forever to get a use case for it. There was no major mandate to it. Without those things, we're a long ways out from the TEF being effective.
Yeah, eHealth Exchange became wildly successful because of the Social Security Administration program. That's where it got its major success. And then for connection to the VA and the DoD, allowing for those federal agencies to connect down to the other organizations. And then the more recent reason is both for direct messaging and for eHealth Exchange was the implementation of electronic case reporting to public health that came out of the pandemic. It started before the pandemic, but it's been rapidly implemented for case reporting. And that is a huge way of reducing provider burden. If you can reduce the case reporting to public health for those 104 separate requirements and make it completely automated and remove that physical burden from the provider and the clinician, you've actually that's the use cases that are really going to demonstrate practical use of health information exchange.
Well, thanks, everybody. I think we're at the top of the hour. I know I've learned a ton. I feel like I have a lot of things I need to research and learn more about now. I hope everyone's enjoyed the conversation. Mark, I don't know if you have anything, or HIMSS Oregon folks, if there's anything you want to add.
Just thank you so much, everybody, for participating, and Laura for hosting, and Paul and Russ and Eric. And all of you for joining. And coming up on June 6th is the annual conference for Oregon. And the recording that we just did here now will be available shortly and be posted on the website. Well, thank you.